We'll get started now. Welcome everybody to the Meet the Expert series. My name is Matthew Leonardi. I'm a gynecologic surgeon sonologist from McMaster University in Hamilton, Canada. It's really great to be here with you all to learn about endometriosis imaging and particularly superficial endometriosis imaging. Who here in the room scans? Put your hands up. Everybody, wonderful. Who here in the room has seen superficial endometriosis on ultrasound already? Lots of you. Okay, so we can make it a bit interactive as well. If anybody has any questions or comments, things that we can all advance and do better on together, we can definitely have that conversation. I'd like to thank GE for the opportunity to present this talk today, as well as ISUOG for putting on a wonderful congress to educate all of us. Here are my disclosures. And many of you already know me a little bit, maybe through the socials, through ISUOG congresses. And if you know about me, you know that I'm really present online. If you're already following along, amazing. If you're not, you might consider. There's a lot of opportunity for learning in the social media space, engaging, research, questions, friendships arise. So it's a really wonderful place to be. And I thought I would start off with this QR code that'll take you to my YouTube channel, which is where I have recently started to share some more ultrasound education that's in the format of shorts. So as you can see, I know it's a little bit small here, but as you can see, we have ultrasound and surgery back-to-back lesson on superficial endometriosis. It's there, you can see it surgically, but it's really hard to see. It's also hard to see sonographically, but you can see it. It's there. And this back-to-back demonstration is what has been able to give me confidence to characterize and truly report superficial endometriosis on ultrasound. The format of the talk today is going to be very lesson-based. So if people like to make notes, there's going to be lessons, and these are the main concepts to take away back home and start to implement them. The first lesson is really in understanding endometriosis subtypes. If you're more an imaging person, this might be a bit of a more new concept. If you're more of a gynecologic sonologist, somebody who operates, you might be well aware of the breakdown. Ovarian is one of the most common subtypes of endometriosis, followed by deep endometriosis, and most common is the superficial endometriosis. As you can see, half of this screen, we believe we can reliably see on ultrasound. Ovarian and deep, I think most of us in the room are doing that day to day. But the second half of the screen is superficial endometriosis, which means there's a huge population of individuals who have historically had a normal advanced pelvic ultrasound for endometriosis. And often that comes along with some invalidation. Things are normal, things are looking good. People don't really want to hear that when it's discrepant from how they're feeling. So this is one of the main reasons I've pushed forward in the approach to ultrasound for superficial endometriosis to pick up this second half of the population. But what is superficial endometriosis? This is controversial. This is changing, like everything. Everything is always changing. We have believed for a long time that superficial endometriosis is endometriosis that is less than 5 millimeters depth of infiltration in the peritoneum. But very recently, in 2021, an international terminology consensus group consisting of groups AAGL, ESGE, ESHRE, World Endometriosis Society, came together and tried to refine the terminology and the definitions. So, for example, we no longer say deep infiltrating endometriosis, now we say deep endometriosis, DE for short. But they also decided, based on their expertise, that superficial endometriosis is now anything that just lines the peritoneum. Anything that has any depth of infiltration by this consensus group, whether they're right or wrong, is I'm not sure, but anything with any depth of penetration is now deep endometriosis. So that does change the game a little bit because a 2 millimeter, 3 millimeter nodule would be classified as deep. These are small, maybe hard to see, and superficial is even smaller. It's only the things that line the peritoneal surface. The second lesson is to know that superficial endometriosis looks different in almost every single patient in terms of the number of deposits, the location of the deposits, how they appear in color, in size. And so you can see here just 8 depictions of superficial endometriosis. Some are red, some are black, blue, some are white, some induce filmy adhesions, some induce peritoneal pockets. This one on the laser pointer doesn't really work. Why don't I just point? This one is vesicular endometriosis. And you know, as a surgeon, you really have to get the laparoscope very close to see that and appreciate the irregularity of the peritoneal surface. So they really can look very different in different people, and it requires a keen eye surgically, and of course it's going to require a keen eye sonographically to be able to pick them up. Lesson number 3 is that they have a variable appearance on ultrasound. That makes sense, right? If they have a variable appearance at surgery, they're going to also appear different sonographically. So this QR code will take you to a paper that I published with the supervision of Professor George Condis and the team from Sydney, back when I was a fellow and PhD student there. This was a technical paper on performing saline infusion sonopodography, pod being pouch of Douglas. And I know around the world we call this space different things. Some call it cul-de-sac, some call it rectuterine pouch, but in Australia it's pouch of Douglas, so saline infusion sonopodography. For those of you here who perform sonohysterography or Hycosi ultrasound tests, this is going to be a very easy technique to adapt because it really is the next step following infusion of saline into the uterus when the fallopian tubes are patent. The fluid will traverse through the tubes, and based on the dependent nature of the pelvis, it will settle into the pouch. And when the fluid settles into the pouch, it separates the structures that are there. It moves the small bowel out of the pelvis, which often settles there. It allows the large bowel to separate from the retrocervix and the back of the vagina. And you can see the peritoneal surfaces actually quite clearly to be able to appreciate irregularities in those surfaces. So as we developed this technique, we started to see these features, and then we started to realize, like all things in ultrasound, we need a language. We need to try to come to a language that describes what we're seeing. And you'll see here the list of the 5 features that we believe best summarized superficial endometriosis, the variable appearance. So you can have an interruption, a small hypoechoic area in the peritoneum that really shouldn't have any major depth of infiltration, as that would be then classified as deep endometriosis. Hyperechoic projections or foci off of the peritoneum. For me, these are actually the most common and the most flashy way to find superficial endometriosis. Rarely you see cystic spaces projecting off of the peritoneal surface. Peritoneal pockets are actually quite common in endometriosis. Endometriosis is an inflammatory disease. It settles onto the peritoneum. It releases cytokines, inflammation markers, and holes in the peritoneum can form, which then re-epithelialize. Those holes become chambers that fluid can fill. And on ultrasound, if you release some pressure, you can see fluid fill these spaces, and they look like a cystic space with an incomplete septation, connecting them to the main pouch of Douglas. And then finally, filmy irregular adhesions. Sometimes this is aligned with peritoneal pockets, and sometimes this is distinct. And you can see this when things are floating. They're sort of flapping in the fluid. Just like the definition of superficial and deep endometriosis has changed, I think how we describe superficial endometriosis is also subject to change. This was the first, as far as I know, depiction in a study that described the sonographic features, but maybe there are going to be evolutions in our understanding of this. And in fact, there have been. So many of you know the Italians and the Spanish have led a lot of literature in endometriosis. This is a paper that recently came out and has pushed forward the nomenclature, the different types of definitions that can exist with superficial endometriosis. And it's really wonderful to see that individuals who have been scanning and seeing this for a long time are starting to come together to push forward this last frontier of endometriosis. And so I would encourage you, as you're scanning, to look for irregularities and to think, how would I describe this sonographically? What are the terms I would use? Echogenicity, irregularity, disruptions. And start to make notes and start to think, because this is a really novel area that we all have to work together to bring forward. Lesson number 4 is to understand that distribution. So I did say earlier that everybody's going to have a different appearance of superficial endometriosis on ultrasound and laparoscopically, but actually there are some patterns. If some of you were in the oral communication session earlier, you saw the presentation that I gave of one of my fellows on the distribution of deep endometriosis, because there are patterns of disease. Even though it's variable, it does behave similarly in people. So, based on one of our studies, which I'll show you in a second, the prevalence of superficial endometriosis is actually highest in the peritoneum of the pouch. That's the space between the uterosacral ligaments, below the cervix, just on the other side of the vagina. And that's exactly where the probe is, on the other side of the vagina. So the pouch of Douglas peritoneum is the closest to us. It's actually the most common site of endometriosis, and this is using surgical identification, not sonographic identification. The ovarian fossa, or pelvic sidewalls, are the second most common site. Again, makes sense. Endometriosis is a dependent disease. It settles, so it's going to be in the lowest parts of the pelvis. The uterosacral ligaments are also common. And as you can see, the vesicouterine peritoneum, the space between the uterus and the bladder, also is common. But that's a harder space to see with ultrasound because fluid often doesn't settle in that space. It can, but it's less commonly there. So, speaking of fluid, lesson number 5, fluid is your friend. Anytime you see fluid in the pelvis, you should get excited. I get excited when I see fluid in the pelvis because it's an opportunity for me to see things that otherwise would be invisible. And when you have fluid, you have a lot more utility of the dynamic tool of ultrasound, the ability to push and pull, shake things, and you can appreciate these irregularities a lot more clearly. So you can see just along the uterosacral ligament there, we have a hyperechoic projection, a hyperechoic foci. And in this case, it's actually moving. It's jiggling. I kind of call this the jiggle test. And you have to tell the patient that you're doing this because it is a little bit awkward sometimes if you're moving the probe in and out quickly. So you want to tell them, I'm going to move the probe, I'm going to try and jiggle the fluid to see how things move. And when you inform them of what you're doing, they're prepared and they're not worried that you're doing something that you shouldn't. You can see the surgical depiction of that superficial endometriosis. You can see it's flame red. It is hanging off of that uterosacral ligament. And so this is a comparison of the two. When there's no fluid there, that small bowel that's just kind of hovering, right here you can see sort of the peristalsis, that's just going to be settling in that space and you're not going to really see these very subtle features. So when there is fluid there, pay attention. Lesson number 6 is to use the dynamic tool of ultrasound. Apply pressure and release. Apply pressure and release. What you're seeing here is the fluid fill the rectuterine pouch as the probe pushes against the uterus and then releases. And if you have too much pressure, that space will close, meaning you won't be able to appreciate the peritoneum overlying the back of the vagina. You won't be able to appreciate the posterior uterine serosa. And when you release, you can see that pressure fill that space and you can start to see irregularities when they're present and you can start to see things jiggling. You, of course, have to move the probe side to side as well, not just in a sagittal view. Sort of a spoiler alert with this. We're also seeing what me and my team are dubbing the triangle sign. So this is not related to superficial endometriosis, but since this clip really depicts it quite nicely, I thought I would hijack the clip. The sliding sign is, of course, a really important test for assessing obliteration of the pouch. But the sliding sign technique in a retroverted uterus has some limitations. You can't ballot the uterus because you can't really reach the fundus of the uterus. And the fundus of the uterus can slide along the bowel, but the rectuterine pouch is actually this space right here in this triangular shaped space. So the triangle sign is a concept that we're pushing forward to evaluate rectuterine pouch, pouch of Douglas obliteration in those who have a retroverted uterus. You can have a negative sliding sign and a negative triangle sign, meaning those spaces don't separate, there's no movement between them. But you can also have a discrepancy. You can have a positive sliding sign and a negative triangle sign when there is deep endometriosis in the plane between the back of the vagina and the uterus. So the triangle sign is something you might see coming forward. We've submitted a letter with a video to the ultrasound journal, and I do think it is a useful technique. So allow the fluid to fill the space. You can see here with that apply-release technique in the anterior compartment, where there is fluid in this case, not that common, but does exhibit there sometimes. You can see the effect of jiggling on that serosal superficial endometriosis, just in the yellow circle there. It's really obvious. This is nothing other than endo. In cases of people having a history of pelvic inflammatory disease, you want to keep in mind that adhesions can form, but that's really the only other pathology, infectious etiologies, that can elicit this particular feature. Some of the other features like hypoechoic irregularities or interruptions could hypothetically be secondary to previous surgery, and as we know, a lot of endometriosis patients have multiple surgeries, so you do want to have that context in mind as well. Lesson number 7 is to think about timing. There's of course planned ultrasound techniques in concepts like sonohysterography, hycosi. You want to plan them in the first half of the cycle after menstruation. And so we have some habits already in planning ultrasounds with time. But in endometriosis ultrasound, we haven't quite done that yet. I don't plan it by timing, so I'm still currently in the no special timing box here. But we know that there are certain events that yield peritoneal fluid much more commonly, in particular ovulation. So we have questioned, maybe the post-ovulation phase is the best time for the evaluation of endometriosis, and maybe superficial endometriosis will be more clearly seen because of the fluid. I've heard hoverings and ideas around whether endometriosis also, in general, endometriomas, deep endometriosis, looks different at different stages of the cycle, as of course we know the endometrium does. So maybe a post-ovulation ultrasound for endometriosis patients is going to help us see endometriosis clearly. Maybe. I haven't seen a study. I haven't done a study. Maybe somebody here will do a study, and it would be great to evaluate this concept. But the category that many of you are already probably doing, maybe unintentionally, is the saline infusion sonohysterography. You're doing sonos. You're often doing them in patients who have infertility. Endometriosis is the most common cause of infertility, so we should be evaluating for endometriosis in that infertile population. And we should be utilizing the procedures we're already doing to go to the next level. So evaluate the cavity for polyps, for intrauterine adhesions, other infertility-causing pathologies. Evaluate the fallopian tubes for their patency, and of course everything else, the uterus, the ovaries. But if the tubes are patent, wait for that fluid to settle into the pouch. If you need them to sit up for a second, that sometimes helps. And then evaluate for endometriosis. This should be eventually what I consider to be the infertility ultrasound, all-encompassing cavity, uterus, tubes, adnexa, endometriosis. So saline infusion sonopodography, I've already given you some information on it and have the QR code for the technique. This is what it would look like after you infuse fluid. So we have a sagittal view on the left and a transverse view here on the right. And as I informed you, the spaces separate. So in a pelvis without fluid, the back of the vagina here, the peritoneum overlying the vagina really just settles onto the rectum. You can't see these peritoneal surfaces. In transverse, we're getting really clear views of the pelvic sidewall, the pararectal space, the serosa of the rectum, and we're seeing that peritoneum overlying the back of the vagina in the pouch really clearly for abnormalities. This is what it should look like after you do saline infusion sonopodography. And we did study it. So this is something that we can say is useful. Is it perfect? No. Is anything ever perfect? No. This is a QR code that will take you to this article, and it was the first ever, again, as far as I'm aware, prospective diagnostic test accuracy study on direct visualization of endometriosis deposits. There had been, prior to this, some indirect evaluations of adhesions, of thickness of features, but this one we looked for endometriosis, specifically superficial. And what we found, as you can see on the right side, we compared the sonographic views to surgical views, where the surgeon, in this case it was Prof. Condas, evaluated things and said, yes, endometriosis, yes, superficial endometriosis. We also compared it to the histology. Again, as we know, not every diagnostic test in endometriosis or in general is perfect. So we wanted to evaluate it very critically against 2 reference standards. This was the strength of our study and something that we haven't really been seeing that much of in other diagnostic test accuracy studies in endometriosis. whereby most groups, most people publishing in this space, are believing of the surgeon. If the surgeon says it is, then the surgeon is correct, but maybe we should be a bit more critical. So that's what we were doing here. And you can see that, again, it doesn't work. In the case of the surgery, we had a very high degree of accuracy whereby we picked up 9 out of 10 cases of superficial endometriosis, and there were very, very few false positives. Interestingly, when we compared it against histology, we had a lot more false positives. Why? We overcall things at surgery sometimes. We see something at surgery and we say, oh, that looks a bit weird, that looks unusual, maybe we should take it out because we're going in to perform excision of endometriosis. And it wasn't always confirmed histologically. Who's right? Is the surgeon right? Is the pathologist right? We actually don't know who's right because there are artifacts at the time of histology, the cautery effect, the crush effect. It's a very challenging thing to discuss the strengths and limitations of diagnostic tests. But again, we wanted to be critical because this was the first study like this. So our specificity did reduce quite dramatically, but surgically, almost everything we saw on scan was identifiable at the time of surgery. Lesson number 8, please never invalidate a patient when the scan is normal. Whether this is a normal basic pelvic ultrasound or a normal advanced ultrasound, or if you're doing SPG, never invalidate the patient when the scan is normal because they have a tremendous diagnostic delay for this disease. And even if it's not endometriosis, their symptoms are real. Pain is always real. It's never made up. And we need to tell patients this. I know that many of us are in the imaging sphere. We may not be managing the patients ourselves, but in my ultrasound world, where I'm not managing them, but I'm scanning them, I always tell them, I believe you. Your pain is real, even if the scan is normal. It still feels invalidating for them when that scan is normal because it's discrepant to what their experience is. But we have to go over and above to validate them, to make sure that they know we believe them, and that the diagnostic process may not stop with that particular scan, may require further laparoscopy for diagnosis and or therapy. So normal scan at this point in time does not mean that there's not endometriosis, and depending on your skill level, how confident you are, you may say, I can safely rule out bowel endometriosis and deep endometriosis, and if you're going to pursue surgery, it's not going to be a complicated surgery, it'll be just superficial endometriosis if we find it. If you're not quite there yet, you may still want to keep a very honest and open mind that maybe there is still deep endometriosis and we have to be on guard. Fortunately, we're seeing that groups like ESHRE are pushing forward this message as well. A normal scan does not exclude endometriosis. We've known this forever, but we're putting it more in the very visible literature because it's really important that everybody's on the same page. We cannot rule out endometriosis on ultrasound or on MRI at this point in time. Lesson number 9 is just keep practicing. Many of you scan day after day after day, and it was really lovely. I was in Adelaide at the Aspire meeting at early September and met a wonderful group from Indonesia. Arti's probably here somewhere, and she's done 100 endo scans since that point and has really advanced in her confidence and in her skill since that time. So keep practicing. Every single time you scan, you should be looking in that posterior compartment for endo, and you should be looking for irregularities in superficial endometriosis. This is how I got good. I saw weird things and I said, what is this weird thing? And I just kept looking and correlated it to surgery. And I have the privilege of being able to do that. But if you don't operate and you have surgeons that you work with, get the surgical pictures, get the surgical reports, so that way you can close the loop and feel confident that what you're seeing is actually real, or not, potentially. So these are a few more depictions of superficial endometriosis. Here's a combination nodule of hypoechoic irregularity with hyperechoic foci. Here's what it can look like at surgery. Here's another jiggle test overlying the back of the uterosacral ligament, sort of a little bit more medial towards the vagina. This one's a really subtle one, but I've zoomed it up for you. So look in the smaller version, the video version as well, just up here. Teeny tiny. All you need is a sliver of fluid to be able to see this. Here we have that classic cystic form, and you can see it's the matching one right here. When you see this amount of disease, this is a huge deep nodule, so that was very easy to see. We don't see every single spot, but the point is you see one, you see two, you interpret it in the clinical context, and you have confidence that this is what I'm seeing. Here we have a depiction of peritoneal pockets. You can see that they also have a bit of a jiggling, a flapping nature. Peritoneal pockets are really common. They're really important to identify because at the time of surgery, they can appear almost normal. There can be small entry points of peritoneal pockets that surgeons can miss. And you actually have to open that pocket, dig to the very base of it, pull the peritoneum out, which is where you'll often find a deposit of endometriosis, and you have to excise that whole pocket. And that's not an easy thing surgically to do, even if it is superficial endometriosis. So identifying these pockets in advance will be a very important advancement in surgical planning. So I'll end with this. Diagnosis is therapy. Diagnosis is an incredibly important moment for a patient in their journey of endometriosis and pelvic pain. Understanding the presence or absence, understanding the extent, having those tools to be able to plan the therapies with confidence. I do believe that our clinical diagnosis of endometriosis, the presumption that there is endometriosis and let's try this tablet or this IUD, there is a missing piece in that story for the patient to have confidence in the clinical decisions that they're making. So diagnosis is a really instrumental point for so many reasons, but it does have a therapeutic value for individuals as well, I believe. I'd like to thank you for listening. I hope it's been inspiring, and I hope some of you will have some questions.
Hi, Matthew. Very nice talk as usual. I just wanted to know, have you seen any difference when it comes to ovulation? Because after hearing your talk, I have been doing a little bit. But post-ovulation, my only concern is sometimes you have debris following a hemorrhage from a corpus luteum, and that could sort of mimic. So I'm wondering, even the post-ovulatory has the advantage that even if the tubes are blocked, you've got fluid, which cannot happen with saline infusion. But my only concern is, so I wanted to ask you your experience in post-ovulatory scans, correlation with surgery. Is there some difference?
There's no literature on this yet. It is a very valid point that you can have rupture of a follicle and there can be some blood. I would say we should use the lesson we know in ovarian mass assessment. When you have a clot within an ovary, there's usually a separation. If you jiggle, if you use the dynamic nature, you can see that clot, that blood move off of the peritoneum.
Okay.
And so you can try and
an obvious clot is yes, but sometimes there are fine debris that sometimes I have a doubt. Is this really little things? So
yeah, I don't have any data to tell you, but like all things in ultrasound, I think one of the things we can do is just bring them back.
Yeah, that's the best thing. Yeah.
Look again.
Yeah. The other thing I thought, because in India we have a lot of PID. And somehow PID doesn't look, other than those big bands of adhesion, PID doesn't have those little flimsy things. So if it's acute PID, everything is, looks very different. And if it's chronic, it's usually more widespread with a thin hyperechoic layer overlying the pelvis. So the confusion between PID and this, in my view, is not very common, even though we have a lot of PID.
I think we have to publish on this, Mal.
That's a
Next
lot
paper.
of work.
Thank you, Matthew, for a beautiful lecture. I have two practical questions. Yeah, when you find such small, subtle findings, do you need to do the laparoscopic confirmation of them?
No.
You never do?
I wouldn't say I never do. We often operate on patients who have endometriosis regardless of the subtype of endometriosis, but it's not based on the scan. It's based on the patient's clinical story, their consent process. We treat the patient. Tina Tellem said this today. We treat the patient. We don't treat the scan. So I don't pursue laparoscopy as a confirmation, but if the patient would like to pursue surgery as a therapeutic approach, then yes, we will operate and get confirmation.
And now another question in opposite. If you're already on the ultrasound, find endometrioma, find even deep endometriosis, do you still searching for these subtle changes, or you think, no, I enough already found, you have to be treated?
Yeah, I'm a little bit less crazy when I see the other deep or ovarian endometriosis. I don't go trying to find all the superficial deposits. Sometimes you see them, and they're there, so you capture them, you characterize them. But I do think we have to be very open-minded about this disease, because there are theories that these subtypes are different pathophysiologic processes. And so if they are different diseases, it may be clinically relevant to say, yes, there is superficial endometriosis, and yes, there is deep endometriosis for future therapeutic planning. I think we have a lot of refinement in the therapies for endometriosis that need to come from the evaluation of ultrasound, some of which you're doing in terms of understanding the natural history of the disease, which we have never been able to understand.
Thank you.
Thank you very much. I have two questions. First, I want to thank you, of course, of your work, because now in Finland we use that, since I saw it the first time in Berlin. And this is great, it works. Although my colleagues doesn't really trust me in this, but it's working. My questions are, first, do you have some kind of feeling how much superficial only endometriosis could be in young infertile women? And the second one is how, because we treat a lot with hormones, we don't operate in Finland as much as somewhere else, and I have somehow the feeling that they are progesterone resistant. We now have Ryoko. I think maybe it's an antagonist of the. Do you have any feeling? Is this working on those? And how many patients you have seen with infertility in those?
So the first question on the subtypes of endometriosis and fertility, I think, is a great question, because we know that endo is one of the most common causes of infertility, and there are lots of ways that it can cause, and sometimes it's multiple ways. But I do think that inflammatory milieu of endometriosis is stronger when there's a lot of superficial endometriosis. As you can see, some of it is very red, it seems very active. I don't think we have yet seen the biochemistry, necessary studies to understand that superficial is more active than deep per se. But if there's no tubal blockage, if there's no ovarian endometrioma, then you can't really attribute the infertility to egg quality per se, decreased ovarian reserve, tubal blockage. So where is that infertility coming from? Most likely the overall health of the pelvis from an inflammation standpoint. And so it is interesting that the fertility clinic we work with in Hamilton is now sending almost everybody who has unexplained infertility for an endometriosis ultrasound. Not quite the SPG yet, but it's a dialogue that we're having to be able to evaluate. And honestly, most of the time you don't have to perform SPG anyway, because there's fluid there a lot. So we will always look for superficial. And I think this is going to be an important area of exploration. The second question was on the effective treatments. I mean, like I was saying to Povilas, I think we have a lot of refinements in which treatments are going to be good for which subtypes of disease. And I think I'm not a pathologist, and I think there is some literature on the behavior of different diseases, how much progesterone resistance there is. I think we should be trying to characterize the disease and refine the treatments. I'll give you an example. One thing that we're finding, this is a little bit of a spoiler alert, but also maybe some of you have seen the same thing. I think there probably is a correlation between polycystic ovarian morphology, polycystic ovarian syndrome, and superficial endometriosis. And I think that in those patients, having a little bit more of a reduction of the estrogen through Orilissa, through Relugolix, through Lupron, depending on the patient and their age, I think that might be beneficial to that superficial endometriosis population in a different way than it's going to be helpful to a deep endometriosis patient population. We're thinking about the mechanism of the disease. So I think we need to pay attention to the subtypes and use that to advance our treatments. Hope that answers the questions.
Matthew, what about the setting, probe, duration of the scan, more or less? There is information about that.
Well, the duration of the scan when you're looking for superficial endometriosis primarily is actually shorter because there's no deep endometriosis. Well, you know, if you've already evaluated the deep endometriosis, you're probably not caring so much about the superficial in a, you know, really critical fashion. And so, you know, you can rule out bowel nodule quickly, USL nodule quickly, and then you go straight to the pouch. So it's actually a shorter scan when everything is normal and you're just looking for superficial. From the settings standpoint and the probe standpoint, the settings, I don't have the words to describe it per se. I have a setting on my machine and I can probably, you know, get a USB and give it to you to plug in. But things are very soft. I really, you know, I make things very soft. I turn the contrast down, you know, I can try and get these settings and share them with you. I think oh gosh, I don't know. I should, yeah, no, it's not an RSPG paper, so don't look for that in that paper. But one of the things I do really like is the higher frequency probe, the 6 to 12 megahertz probe. Yeah, that is something that does help, I think. I will get back to you on the other stuff.
Very nice presentation. Sorry. Just a question coming with the question before. Do you think this method would help monitoring the results of a treatment? And another question would be, do you think of a mapping of the pelvis in where you would put all the small lesions there and find, and that will help you for monitoring?
Yeah, absolutely. I think we are at a very pivotal moment here where we can understand how endometriosis changes with time by looking over and over again. There are some limitations to that. We're not perfect. You might not see something on a scan today and then you look again in 3 months and it might have been there, but you just didn't see it. So I think we have to be very careful to say things are progressing or regressing because the imaging, particularly for superficial endometriosis, is not perfect. And so I think we do have to be starting to evaluate that under various therapies or no therapies. Expected management. Not every single patient with endometriosis has symptoms. There's going to be a talk later today on asymptomatic endometriosis and what does that mean. So I think this is going to be a really exciting area coming forward. The microphone is just...
I've got the
Yeah, I can hear you loud. I'll repeat the question. The question was, do I use or advocate for antibiotic prophylaxis before sonohysterography? The answer is no, I don't. If I have any concerns with hydrosalpinges, hematosalpinges, I'm first of all questioning whether we should do it or not do it. But if somebody has asked me to do it despite that, I will prophylactically treat them with antibiotics. Yes, but otherwise, no. Oh, there's one with the microphone here.
Matthew, you alluded to an association between PCOS and superficial endometriosis. I wasn't aware of it, but I had noticed I have a lot of deep infiltrating endometriosis patients sent for it who seem to have PCOS and nothing else that I can find. Obviously now I'll be looking more for superficial endometriosis, but what is the association?
As far as I know, there's only one paper that has demonstrated this. It's actually from a Korean group that demonstrated a higher relationship between PCOM, not necessarily the syndrome, but the appearance, and superficial endometriosis. And this is what I'm seeing. And I was seeing this before I found this paper, but of course, you have this question, so you look up the literature, and then I found this other group that has identified that. And so either there's an association and the symptoms that they're having are from superficial endometriosis, but they also have PCOM, or maybe there is a pain mechanism of PCOM that we haven't really recognized. Whether that's the pro-inflammatory effect of estrogen, the size of the very large ovaries, we are all taught PCOS is not painful, but like everything, I think we should question it.
Yes, I've often had to explain to those patients that maybe their stroma is stretched and that might be painful, or that they're a bit more prone to getting cysts than the average patient, but I guess now there might also be superficial endo as well.
I think there's something there, and I think those other theories that you've just mentioned are very valid and good ones. I think we have to consider that, it's not just a hormonal endocrinology type issue. There might be other symptoms that we have not fully understood.
Good morning, Professor. I'm Dr. Ku from the Philippines. I'm just curious, how much fluid do we need to instill to create those great images?
Thank you for the question. I'm not officially professor yet, even though the program said that one day. The amount of fluid is variable. So I think the goal should be to put what you need. With sonohysterography, at least in my experience, the amount doesn't regulate the pain as much as the catheter and the initial infusion. So I think we actually do have the ability to be quite generous with the amount of fluid. In our study, our prospective study, the median amount of fluid which was used was 60 milliliters. That was done intraoperatively though. So we weren't able to evaluate how much pain came from that amount. But in real life, when we do sonohysterography, sometimes you need quite a bit more to get the distension, to get that tubal assessment complete. And I personally, anecdotally, do not find that the amount correlates to the pain. It's usually the beginning of the procedure when that becomes most uncomfortable for people.
Thank you.
You've been doing this superficial endometriosis for some time now. So I want to know, in your experience, how many of these you think progress to be, because you said maybe there are two different pathologies or two different pathophysiologies. So do you think these progress, and because in that case, keeping them at bay when they're just superficial would help us see less of deep endometriosis? So I wanted to
I'll repeat the question. So Mala asked if I've seen a progression from superficial to deep, and the answer is no, but I don't know if that's just experience or the truth. I think there are a few studies that we can use to try and help answer this question. One of the classic RCTs in surgery for endometriosis back in 2004 from Jason Abbott looked at patients at 2 time points surgically. Majority of patients stayed the same over 2 surgeries. Interestingly, 1/3 got worse and 1/3, or maybe it was a quarter and a quarter, got worse and got better. The disease seemed to look better than the first surgery. I don't think when we find the superficial endometriosis, it does change. I sort of have this theory that deep endometriosis is probably like a big bang event. We were talking about it last night at the Voluson party. When does that become deep? They're not probably born with a deep endometriosis nodule, but we haven't really captured that progression yet. Is it from superficial, or is it a deep endo deposit that's from embryology that just gets bigger with time? I don't know the answer. Wonderful questions. Thank you, everybody. If you have more questions, I think we'll probably have a chance to talk over lunch as well.